Welcome. Today, we're diving into a complex and often underdiagnosed lung condition known as combined pulmonary fibrosis and emphysema, or CPFE. This disease presents a unique challenge because it combines the destructive effects of emphysema with the scarring of pulmonary fibrosis, leading to a particularly debilitating respiratory condition. Join us as we explore the intricacies of CPFE, from its causes to potential treatments. The exact cause of CPE remains unclear, but several factors are strongly implicated. The most significant is undoubtedly smoking. In fact, CPFE is overwhelmingly observed in current or former smokers. Other potential contributors include environmental exposures like occupational dust and pollutants, genetic predisposition, and in some cases, even underlying autoimmune disorders. It's important to note that the interplay of these factors can vary from person to person, making it a complex puzzle to unravel. CPFE's pathophysiology is a double-edged sword. Emphysema involves the destruction of alveolar walls, the tiny air sacs in the lungs where oxygen exchange occurs. This leads to enlarged air spaces and decreased lung elasticity. Pulmonary fibrosis, on the other hand, causes scarring and thickening of the lung tissue, restricting its ability to expand and contract. The combination of these processes results in a unique pattern. The upper lobes of the lungs are primarily affected by emphysema, while the lower lobes are dominated by fibrosis. This uneven distribution of damage contributes to severe gas exchange impairment and pulmonary hypertension, a dangerous elevation of blood pressure in the pulmonary arteries. Epidemiologically, CPFE is believed to be underdiagnosed. This is partly because its symptoms can overlap with other lung diseases like COPD or idiopathic pulmonary fibrosis. Studies suggest that CPFE may affect a significant proportion of individuals with emphysema or pulmonary fibrosis, particularly those with a history of heavy smoking. Further research is needed to accurately determine the prevalence and incidence of this condition across different populations. The signs and symptoms of CPFE can vary in severity, but they commonly include shortness of breath, especially with exertion, a persistent dry cough, and fatigue. Due to the pulmonary hypertension associated with CPFE, individuals may also experience chest pain, lightheadedness, and swelling in the legs and ankles. A key feature that distinguishes CPFE is often the presence of relatively preserved lung volumes, which can mask the severity of the underlying disease. Digital clubbing, a widening and rounding of the fingertips, can also occur in some cases. Diagnosing CPFE requires a comprehensive approach. A thorough medical history and physical examination are essential. Pulmonary function tests, such as spirometry and lung volume measurements, can reveal abnormalities in airflow and lung capacity. A high-resolution computed tomography, or HRCT, scan of the chest is crucial to visualize the characteristic pattern of upper lobe emphysema and lower lobe fibrosis. In some instances, a lung biopsy may be necessary to confirm the diagnosis and rule out other conditions. Currently, there are no established classifications or distinct types of CPFE beyond the basic definition. However, research is ongoing to identify potential subtypes based on the severity of emphysema and fibrosis, the presence of pulmonary hypertension, and other clinical characteristics. This could lead to more personalized treatment approaches in the future. Treatment for CPFE focuses on managing symptoms, slowing disease progression, and improving quality of life. Smoking cessation is paramount. Pulmonary rehabilitation can help improve exercise tolerance and breathing techniques. Oxygen therapy may be necessary to maintain adequate blood oxygen levels. Medications used to manage COPD, such as bronchodilators, may be helpful. For pulmonary fibrosis, anti-fibrotic medications might be considered, although their effectiveness in CPFE is still under investigation. In severe cases, lung transplantation may be an option. Prevention strategies for CPFE largely revolve around avoiding risk factors. The most crucial step is to never start smoking or to quit smoking if you currently smoke. Avoiding exposure to occupational dust and pollutants, maintaining a healthy lifestyle, and prompt treatment of any underlying respiratory infections can also play a role in reducing the risk of developing CPFE. The prognosis for individuals with CPFE is generally poorer than for those with either emphysema or pulmonary fibrosis alone. The combined effects of these diseases lead to a faster decline in lung function and a higher risk of complications such as pulmonary hypertension, heart failure, and respiratory failure. Recent research is focusing on identifying biomarkers that can predict disease progression and response to treatment. Studies are also exploring novel therapeutic targets, such as pathways involved in inflammation and fibrosis, with the goal of developing more effective treatments for CPFE. Lung transplant is a consideration for select patients but carries its own risks.